Okay, right. So I hope everybody's been keeping well, safe, all that jazz. Go through Psychopharm today because it's been requested a few times. As per usual, anyone got any questions at any point, put them in the chat. If you think of them afterwards, message me. I'm sorry I didn't manage to put in any SBAs, but I'll keep on quizzing and stuff as we go in just because of post finals shenanigans, muckery, so on. But yeah. So, we'll go through the base principles that I basically always use whenever I'm dealing with any pharm, but these are the ones that are most important for psychopharm, I'd say. And then go through antidepressants, go through antipsychotics, go through mood stabilizers, with essentially the most important SBA stuff, but I've put some OSCE stuff as well because it is important. Right, so the base principle stuff that I wanted to do was basically the way I break down pharm to make it easier for myself, at least the way I find it easier, is to try and break it down to what receptors are targeted by a drug, what happens when you activate this receptor, what happens when you block it, what drug, let's say if I think of an SSRI, what does it actually do? So, okay, serotonin, cool. Okay, so that makes sense why it does this, makes sense why it's side effects of that. So for example, if we start dopamine, so dopamine, we're thinking antipsychotics, which block 3 out of the 5 dopamine receptors, so 2, 3, 4, which are called the dopamine 2-like receptors. And we know that since activating dopamine receptors generally increases movement, blocking them causes bradykinesia and rigidity and all the Parkinsonian stuff, the extrapyramidal stuff, because it's the part of movement that's outside of your pyramidal corticospinal tracts. So block dopamine receptors, you get those things. We know that when somebody takes dopamine agonists, like bromocriptine, the ones that they use in Parkinson's disease, or also anything which increases serotonin levels, like cocaine or amphetamine, people become quite impulsive. So that's an agonistic effect. Blocking it can make people quite subdued, for example. We know that dopamine inhibits prolactin, so by blocking dopamine, you get hyperprolactinemia. And what's the stuff that you get with hyperprolactinemia? Because this is kind of important for side effects, because the hyperprolactinemia side effects can be quite bothersome. Good. Galactorrhea, which is not great. Gynecomastia, breast tenderness. So the breast tenderness is really important in women as well. So people only think when it comes to breasts, oh, gynecomastia, but breast tenderness, so it's quite uncomfortable. Amenorrhea, yeah. And what's the kind of significant quality of life one? So you've got your period stopping, you're lactating outside of pregnancy, and if you're a man, gynecomastia, which can be quite uncomfortable and distressing, breast tenderness, which is uncomfortable, but there's a significant quality of life one. And this is a general side effect of a lot of the psychiatric drugs, which not quite infertility, but it's a side effect of a lot of the antipsychotic drugs, or yeah, perfect libido. So libido is a big thing with a lot of the psych drugs, antidepressants and antipsychotics, and also mood stabilizers, and it often doesn't get counseled about when you're consenting patients. So it's quite important if you are sort of giving the patient informed consent to mention things like this could knock out your libido, make it harder for you to get an orgasm, harder for you to sustain an erection if you're a man, because if you imagine someone who's quite depressed and then you take out their sex life, it'll probably make them more depressed if that is something they've got going on for them. So hyperprolactinemia is associated with all the stuff that you've mentioned, but also sexual dysfunction. Acetylcholine through the muscarinic branch, so they don't. The psychiatric drugs don't really touch the nicotinic branch of acetylcholine's function, so all the somatic muscle control. But by now, most of you will be familiar with the muscarinic, so sort of anticholinergic effects through there, so all your constipation, urinary retention, tachycardias, and so on, and then the agonism side of things, which is the exact opposite. Serotonin is an interesting one. Some of the notable things that don't often get mentioned. So obviously there's a whole point of giving SSRIs, which is that somehow increasing serotonin levels affect mood. It's not direct. It's not the whole serotonin is a happiness hormone. The more serotonin you have, the happier you are. It's a much more indirect and not really understood effect even after decades of research. It also affects bone mass in quite a complicated way. There's a very sort of fine balance between osteoblastic and osteoclastic effects mediated by serotonin, but also serotonin's got GI effects, so it's pro-motility and pro-secretion, including gastric acid, which is kind of important, as we'll get to. And also it does input onto the autonomic nervous system as a sort of, so it's not directly involved in it, obviously, but there is some input onto it, which is why serotonin syndrome does have a lot of autonomic symptoms. And then the last two, the only things that really matter with these ones is histamine is very important centrally, so the histamine 1 receptor for keeping you awake and making you wake up, which is why old school antihistamines used to knock people out and still do, so chlorpheniramine, for example. So when you block it, you get really, really drowsy. Like I think something like if you give, what's it called? Mirtazapine, so one of the antidepressants, I think at a normal dose, within an hour or so, 80% of healthy controls will be feeling very drowsy. So it's very potent. And then talking adrenaline, noradrenaline, there's actually an influence on appetite, which is important because weight and appetite is influenced by a lot of these drugs, which can be both a good thing and a bad thing, but also the whole smooth muscle contraction thing. So when you block these, as some of these medications do, you get increased appetite, which will lead to weight gain, but also smooth muscle relaxation. So that's things like the big one for that is orthostatic hypertension, which is scary in older people who often have higher rates of depression because then things like falls happen. Right. So if we start with SSRIs, I'll just quickly go through sort of the main the main points with them before we go on to some more specific things. So it's important to remember that SSRIs aren't just for depression; they're quite useful in anxiety disorders. So the thing that's worth remembering, which the couple of you who were there just when Anoush mentioned it right at the start, for things like anxiety disorders, that's OCD, PTSD, as well as general anxiety and panic disorder, they're often given at a higher dose. Again, the reasoning is not understood, but you'll see them given at a higher dose than you might see for something like depression. So, for example, fluoxetine tops off at 60 milligrams. License-wise, it's supposed to be 60 milligrams, but you might see people, for example, with OCD on a higher dose than 60, going to something like 100 milligrams. There is the risk of congenital heart defects in pregnancy, but on balance, if you're going to have a woman who's going to be incredibly depressed and suicidal during pregnancy, or an increased risk of birth defects, you'll probably go for the former. If they are breastfeeding, paroxetine and sertraline is preferred. If it's a kid, fluoxetine is the only one that's licensed. If they've had an MI, sertraline, citalopram, escitalopram, QTC prolongation. These are all the little SBA tidbit stuff. And also they're quite good in terms of renal impairment. You don't really need to worry about them renally. There are only two contraindications, which is someone who's got really bad epilepsy because they can lower the seizure threshold, and mania. If someone is manic, all antidepressants are contraindicated, which does make sense. Cautions, and here are the bits which are a bit more specific. If someone's got a history of bleeding disorders, anyone know why that is? Something to do with serotonin's function. Oh, sorry, bleeding disorders is there twice. I'll make sure to change that. Yeah, so they increase the risk of GI bleeds. Anyone know why that is? That's all right. So serotonin actually inhibits platelet function. So your platelets don't work as well. So bleeding disorders, especially if they've had a GI bleed, if they've had an ulcer, for example, epilepsy, mania, we've said, all the antidepressants seem to raise intraorbital pressure for some reason. So if they're at a higher risk of acute angle closure glaucoma, then, and the big one, SSRIs in the elderly, is the risk of hyponatremia because of SIADH. And with overdoses, SSRIs are actually quite good. Now we come to a more OSCE thing. So if you're consenting somebody to an SSRI, what are important points What are sort of the big takeaway points that you'd want to say? And I think the way that's, whilst you're typing this out, I think the way that's quite useful for this is I will sit down and think, if I was to be taking this medication, what would I want to be told? What do I want to know about? Right. What have we got? Good. Don't stop taking it suddenly, because withdrawal syndrome is a very big thing with antidepressants. It doesn't work immediately. Very good. Lots of people will expect that medicines start kicking in straight away. They don't with antidepressants. Good. Follow-up is very, very important. Good. You're ticking all the boxes that I have so far. Because there's that risk of paradoxical suicidality. Follow-up is really, really important for patients on antidepressants. Good. So common side effects and gastrointestinal stuff is by far the most common thing in terms of side effects with SSRIs. Fantastic. So you're all doing, that's all really, really good. Yeah, perfect. So if it's not working, we can change this and we will change this. So it's not like, oh, there are further options. So this is a bit of a sort of that's a really important one. They're not addictive, even though they've got withdrawal symptoms. Doesn't mean they're addictive. So I sat down and thought, if I was to consent a patient for an SSRI, what sort of things do I want to ask? And it goes a bit like this. And really, this is something you can use in your screen. You can adapt it pretty much to any of actually any medication. But it's sort of starting off with what quite a few of you said, which is why we give the medicine. But it takes a number of weeks. If it feels like it's not really doing anything, we can change the dose and then maybe consider another medicine. If it does make you feel better, you're going to stay on it for at least 6 months. So this is every antidepressant. Once the patient starts feeling better, they stay on it for at least another 6 months. Otherwise, the risk of relapse is pretty high. Side effects most commonly affect the digestive system, but these go away after a few weeks. Some other common ones, so effects on how awake the person feels, how tired, weight change, pins and needles. So we talked about libido, and in Urosky, the whole leaflet thing is actually a thing in terms of getting marks and stuff like that. It's also important to reassure a patient, because it's quite intimidating if you've ever sort of opened even a pack of paracetamol and looked at the side effect list and you go, oh my God, this does everything. It's quite important to say to the patient, this doesn't mean you will get these. Some people get none of these, some people get a few of these. You're not going to get everything that's on this list. So stuff that we're checking for, so bleeding disorders or anticoagulants, we've talked why. SSRIs or anything really that increases serotonin levels increases the risk of bleeding. Have they ever had any ulcers? For pretty much the same reason. We did also mention that serotonin increases gastric acid secretion. So what you might see is some people get put on a PPI as well as an SSRI, but that's not a gold standard thing. It's just a clinical risk. Okay, maybe I should put this person on PPI as well. Osteoporosis. So there's a risk, especially with long-term SSRI use, of osteoporosis. So sometimes you might want to take that into consideration and consider things like vitamin D and calcium supplementation. Pregnancy is generally a good one to ask about, and then seizures and epilepsy because they lower the seizure threshold. And then you've mentioned the two really important points, which is paradoxical suicidality. You will review a patient who started on an antidepressant at least every 2 weeks for a good few, like a month or two. If they're younger, you might even do it weekly. So I think if they're under 30, some people say under 25, some people say under 30. I like to be on the safe side, and if it was a patient who was under 30, I'd ask to see them in a week, and then maybe the week after that, and then make it 2 weeks, just to explicitly screen, not just for how they're feeling, but if they're feeling suicidal at all. Safety net, if someone's feeling suicidal, so remember, if you're feeling suicidal, you can go to your nearest emergency department if you're feeling acutely unwell. And finally, don't stop your medicine suddenly, because withdrawal symptoms happen. And the withdrawal symptoms of SSRIs are very, very varied, all the way from GI stuff to electric shocks to almost a malaise type picture. So always warn patients not to stop that. On that topic, actually, so with most antidepressants, we try to bring them down quite slowly. There is one antidepressant where you don't have to worry about that as much because it's got such a stupidly long half-life that you can bring it down faster than the others. Anyone know which one that is? So for reference, most antidepressants will have a half-life of 8 to 18 hours, maybe. Perfect. Francesco's got it. So fluoxetine's got a half-life of like 3 weeks. It's insane. It will stay in your system for a very long time, so you don't need to worry too much about withdrawal. Okay, very good. Right. So moving on to SNRIs. What's the most common SNRI that you're actually going to see for patients with depression? Because there are quite a few in practice, but only one of them's the one that you really see in depression. There's two others I can think of, but you don't really see them for patients with depression. What's the depression SNRI? Perfect, venlafaxine, yeah. So venlafaxine is SNRI. Couple of other SNRIs, you've got duloxetine, which is more diabetic neuropathy, and bupropion, which is the smoking cessation one, but the latter isn't even licensed for depression, and duloxetine is very rarely used in depression. SNRIs, there's not much that you need to know extra, other than the stuff that's added on to SSRIs because of the noradrenaline aspect. So if you were to try and logic it, you've got increased levels of noradrenaline because you've got reuptake inhibition of noradrenaline. What kind of side effects and cautions might that make you think about if you're keeping up if you're maintaining levels or even raising levels of noradrenaline? Perfect. Hypertension is the biggest one. And actually, it's one of the only monitoring requirements I can think of with an antidepressant is that a patient on venlafaxine should have their blood pressure monitored. And once you start thinking about blood pressure and the cardiovascular stuff, everything else comes in. So patients with heart disease, patients with arrhythmias, all that sort of thing gets added on with venlafaxine. So if we just quickly have a look, uncontrolled hypertension is the big contraindication for venlafaxine. You've got arrhythmias, we've mentioned, diabetes, heart disease, bleeding disorder stays, epilepsy stays, angle closure glaucoma stays, and mania is constant. Points, you don't use it in pregnancy and breastfeeding, and unlike the SSRIs, which are pretty good with renal function, venlafaxine does need adjustment once they drop into stage 4 CKD. And the other notable thing is that withdrawal is worse with venlafaxine than other antidepressants. Add on in terms of the regular SSRI side effects, things like palpitations and feeling short of breath. All antidepressants can increase how sweaty a person feels. Like some people can get full on night sweat style sweating, like waking up drenched. Venlafaxine is by far the worst for this because of noradrenaline, and also causes the paradoxical suicidality. Because of the noradrenaline, unlike SSRIs, which are pretty safe in overdose, noradrenaline is not. People end up on intensive care with venlafaxine overdoses. It's supportive. There's not really much you can do for it because it distributes everywhere. It's got a really high volume of distribution, but it's really dangerous in overdose. So do consider that when you're thinking about who to prescribe venlafaxine to. Okay. So this moves us on to tricyclic antidepressants. So tricyclic antidepressants are a good example of where we can properly start thinking about well, the little table thing over here in terms of what, does it bind to this, therefore what side effects will it cause? So with tricyclics, question. It appears that they have a slightly higher efficacy. So that's literally the only reason. That's a really good question. What's the point of giving venlafaxine if it's higher risk and more side effects than SSRIs? It's thought to have evidence suggests even that it's got a slightly higher efficacy than SSRIs. So often it's reserved as a second, not even second, really third, fourth choice option. But that's basically it. It's the same thing with the tricyclic antidepressants, actually. The tricyclic antidepressants do appear to have more, to be more efficacious for depression, especially severe depression. The problem is their side effects are really bad and they're dangerous in overdose, which is this really unfortunate balance. So, important things with tricyclics. the dose for depression is a lot higher than the dose for neuropathic pain or the other things you might use it for. So neuropathic pain, for example, you might start off with 5 milligrams, maybe even 10. Depression, you start off at 50 twice a day. So that's 10 to 20 times more than the starting dose for neuropathic pain. It's a really high dose, and that brings the problem of overdose and side effects into it. If we think the same SSRI, the same side effects as SSRIs, because tricyclic antidepressants cause serotonin reuptake inhibition. The same side effects as SNRIs, because they cause noradrenaline reuptake inhibition, but they also bind in a sort of dirty fashion to histamine 1 and alpha-1 adrenoreceptors. So a big side effect is tricyclics knock you out. They really knock you out, especially at depression doses, and also the stuff like postural hypertension or weight gain. So the really big things are the drowsiness and the weight gain on top of the stuff that you already get from SNRIs and SSRIs. This kind of leads on to the fact that they are contraindicated in patients with arrhythmias, heart blocks, and you have to be quite careful with them in cardiovascular disease. So they've got a longer list, of cautions and contraindications. You don't need to memorize them. The important thing, the single most important thing to remember with the tricyclic antidepressants is really high suicide risk. In terms of drugs, which are most common, the drug which is most commonly used and completed suicide through drug overdose is amitriptyline, because it is just lethal. It's very cardiotoxic, which brings us on to tricyclic antidepressant overdose. What sort of things, let's say you've got a person coming in and you don't know what they've taken, what sort of things make you think that they might have taken a tricyclic antidepressant? If we think of signs and symptoms first, and then we can think of other things. Let's say a patient who's been brought in by ambulance. So, because they are antimuscarinic, would they get pupil constriction or pupil dilation? Since they've got a very strong antimuscarinic, that's all right. But you've got the pupils is an important thing. So they will have dilated pupils. Something which is difficult is a lot of drugs will cause dilated pupils. They're nowhere near as specific as pinpoint pupils. Cocaine will do it, MDMA will do it, amphetamines will do it, but they'll cause dilated pupils. What else based on the side effect, the receptor profile even? Good. So there'll be urine retention. You might be able to palpate a bladder, and suprapubic tenderness. So there'll often be an acute urinary retention, dilated pupils. Good. Quite agitated, sometimes even decreased GCS. And then what's the telltale thing on an ECG? It's not really a telltale thing. Sorry, I shouldn't have used that word. Perfect. Yeah, but it is prolonged QR. Yeah, it is prolonged QRS. Wonderful. Yeah. So prolonged QRS and a patient if it gets so prolonged, it starts looking like a sine wave, and sine waves are seen in very severe, very severe tricyclic overdose. If anyone pictures sort of sine waves back from GCSE physics and stuff like that, if the ECG looks like that, it might actually be a really bad tricyclic overdose. But prolonged QRS is the most common one. So dilated pupils, some form of confusion or decreased GCS, and prolonged QRS is basically tricyclic until proven otherwise. So for the arrhythmias caused by tricyclic overdose, what is our first line management? Because a lot of the other stuff can make it worse, like adenosine and so on. So there is one drug which is most effective for these. Yeah, perfect. Bicarb. So intravenous bicarb is what you usually give. Otherwise, everything else is supportive. maintain airway. If a person's presented within an hour, generally of most overdoses, what can you give them? Good, charcoal, fantastic. So you can give people activated charcoal. Generally, if they're presented with an hour of most overdoses, there are some exceptions, we will see that later. And if they're having seizures, what can you give them? This is sort of your general advanced life support stuff. If someone's having seizures, you've got a cannula in. Hint, it is the same as status. It's the same management as status. So what's your first line if you've got IV access? Yay, perfect, Loraz. Yeah, so we give them lorazepam. So just to quickly run through what we just said as a sort of recap. So increased efficacy, but they're not great in terms of the fact that they will kill a person quite easily, and the side effects are worse because you're adding on not just the side effects of SSRIs and SNRIs, but now you're also chucking on top of it antimuscarinic side effects and also antihistamine side effects. So not great for people who work with heavy machines, not great for people who work with whose job involves driving big vehicles or any vehicles really. Also, they enhance the effects of alcohol. So if you drink, you get even more drunk, and they're a bit dangerous in hepatic dysfunction. So there's caution with that. More contraindications, especially to do with arrhythmia stuff. Same cautions as previous ones, but with added stuff like BPH because they cause retention, so they'll make it worse. And also, you don't give it to people who are really suicidal because that's just a recipe for disaster. And we've talked about all the stuff that can go wrong in terms of side effects. We've talked about the TCA overdoses as well. And the big thing to take away from that is the triad of prolonged QRS, dilated pupils, and some alteration in cognitive state. And also, if there's an ECG change, give them bicarb. That's really the high yield stuff from there. Right, other antidepressants. So the only other two that I will talk about, because there are lots of others, and I'm not going to talk about stuff like trazodone or whatever, is mirtazapine. Anyone want mirtazapine and one other type? Anyone want to take a guess as to what the important SBA stuff is for mirtazapine? And it's particularly to do with what patients are you more likely to give mirtazapine to? So because, yeah, so the drowsiness is actually useful in this case. Right, okay. So Christina's gone for insomnia. Yeah, so patients who are struggling with insomnia because of their depression, and then the other bit are patients who aren't eating. They've lost their appetite. So yeah, perfect. So patients with a poor appetite who are struggling with their sleep, one or the other, mirtazapine is really, really good for that sort of thing. One of the reasons we like it is that actually it's almost as safe as SSRIs and overdose. It's a lot safer than tricyclics, which is interesting because it's a tetracyclic antidepressant rather than a tricyclic. So adding on one more benzene ring has somehow made it much, much, much safer. Its strongest action is actually with histamine, which is why it's so powerfully sedative. And instead of doing reuptake, it just blocks receptors. So it blocks some serotonin receptors. It doesn't do any uptake inhibition, and it's very weakly anticholinergic. So actually, apart from the weight gain and the drowsiness, its side effects it's very different to a lot of the other antidepressants. So frail old patients was mentioned. That's actually one of the risk groups because it makes people so drowsy and it increases the risk of falls. It's a bit of a toss-up because you have elderly patients who often depression manifests more physically with poor appetite and poor sleep, but also these are the people who are far more vulnerable in terms of falls. So you do have to sort of assess things like falls risks. And yeah, I mean, that's completely fair because literally it's wow, this is really great for old people because when they have depression, they usually can't sleep and they usually lose their appetite. but crap, also I could make them fall and break their hip. How good does this person walk? That sort of thing. The other one that we'll talk about is monoamine oxidase inhibitors. The only thing you really know about them in terms of SBAs is you have a person on a monoamine oxidase inhibitor, and then they eat something, and their blood pressure skyrockets. They get a hypertensive crisis. What sort of dietary things cause this? The cheese reaction. What sort of things other than cheese? Yeah, that was a bit of a spoiler. Well, maybe a better question is what is it that's in the cheese that's causing this reaction? Tyramine, wonderful. So tyramine is an amino acid. It's the precursor to all of your monoamines. Remember, your monoamines are threefold. They are your serotonin, your dopamine, and your noradrenaline/adrenaline. And if you're taking lots of tyramine, you make more of those neurotransmitters. However, monoamine oxidase, which is the enzyme which breaks them up, is being inhibited by this drug. So you don't really break them down, and high levels of noradrenaline and adrenaline will cause your blood pressure to go up. Dopamine also makes your blood pressure go up. It's why they use it as an inotrope, inotrope in ICU. And yeah, so that's the cheese reaction. You get it with anything with tyramine in it. Wine, salami, Marmite is one which I found out recently. Marmite and Oxo. So some stocks could actually cause it. Thing is, they're not really common because of the cheese reaction fear. However, there's some evidence that maybe that was overhyped, so they could be coming back. The only one that you'll probably hear is phenelzine, and I've never seen it, and I've done a lot of psych, like voluntarily done a lot of psych, and I've never seen a patient on phenelzine. Because of the vascular stuff with high blood pressure and so on, vascular paths are not a good idea. Well, giving to them is not a good idea. Pheos also not a good idea. Makes acute porphyrias worse. And yeah, we don't like giving it to old people because you might give them a stroke. Okay, so that's antidepressants. Now, so I've got a patient who is on sertraline, and one of the things that that helps my patient cope with his depression is some recreational drugs, and the patient actually finds using LSD quite useful. He dissociates whilst using it, and he finds the dissociation somewhat comforting. What am I scared of? My patient on sertraline who's taking LSD. Good, serotonin syndrome, perfect. Now, a point of difficulty can be distinguishing between serotonin syndrome and neuroleptic malignant syndrome, not just in SBAs, also in real life. What sort of things point towards one rather than the other? Time course, good. So what sort of time course are you thinking, Christina? Really good, perfect. That's really, really good. So my patient who takes sertraline went to a party, took some MDMA. 2 hours later, he's in the local ED with autonomic dysfunction, blood pressure's plummeting, heart rate's going up. My other patient, who I've prescribed quetiapine to, who's never had any antipsychotics before, maybe might end up in A&E 4 weeks later, for example, with neuroleptic malignant syndrome. So time course between exposure and the actual onset of symptoms is really important. What other stuff? Yep, past medical history, really good. Yeah. So, yeah. Good, the rigidity. Tell me about that. And reflexes, good. So tell me about the difference in reflexes. Good. 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 So, yep, clonus. And what about the rigidity? Because the rigidity is a pretty big one. So sure, you've got stuff like hyperreflexia and so on, and serotonin syndrome, which is less likely. And so really, it's just a matter of rigidity itself. Patients with serotonin syndrome don't tend to get really rigid. Patients with neuroleptic malignant syndrome will be very, very rigid. You move their wrist and the whole arm will move. Not even like the elbow will move. You take the wrist and the whole arm is going to move. That's how rigid they are, because dopamine receptor blockade will cause extrapyramidal side effects. You don't tend to get too crazily rigid. So you can, in serotonin syndrome, you can get spasticity. But someone remind me, what's the difference between spasticity and rigidity? You've brought this upon yourself. Yes, perfect. Velocity. Yeah. So if it's velocity dependent, it's spastic. If it's velocity independent, it is rigidity. And what that just means is that whilst I'm doing this, if it's rigidity, it's the same regardless of how fast I do it. If it's spasticity, maybe when I'm doing it quite slowly, it's fine. But if I try to rush it, then it becomes harder to move it. Very good. So spasticity is more serotonin syndrome. Rigidity is very much neuroleptic malignant syndrome, and that is one of the best ways of telling the difference. So, just to quickly talk about it, mentioned the cognitive stuff, so headache, agitation, confusion, hallucinations, which you can get in NMS as well. The autonomic stuff, so mainly tachycardia, not hypercardia. Well done me. Did my finals lesson a week ago and can't remember these things. And serotonin also causes prokinesis in the GI tract, so they'll get stuff like diarrhea, which you're not going to get with NMS. Remember, lots of things can precipitate it, including stuff that you might not think of. So triptans, valproate, tramadol is one a lot of people don't think of. Patient is coming in for an operation, is in some pain, you give them tramadol, turns out they're on sertraline, now they've got serotonin syndrome. So the time course was mentioned by Christina, and that's absolutely spot on. And what you're going to do, you are going to stop giving them medicine and you're going to give supportive care. Some places have cyproheptadine, which is a 5-HT receptor antagonist, so it blocks the effect of serotonin. Most places don't have that, though, and it's mainly supportive and escalate to a higher intensity unit if you have to. Right. So that's antidepressants, which are the bulkiest ones by far. Antipsychotics aren't as bulky, fortunately. And to be honest, when talking about antipsychotics, you don't obviously there's a typical and atypical divide, but the reality is you can get extrapyramidal side effects with atypical antipsychotics at a high enough dose, and you can get metabolic side effects with typical antipsychotics as well. It's just they're way more common in typical antipsychotics because they bind more strongly to the dopamine receptor, and the metabolic ones are way more common with the atypicals. So we'll talk a bit about clozapine in a second because that's kind of special. But I'll actually start off with a question that I will have ripped off completely from my exam last week, or was it the week before last? I don't know. What is time? You have a lady who is an inpatient on a mental health ward. She's manic actually, and she's become very, very agitated. And she's threatening to hit the cleaner because she says that he's looking at her funny. She's agreed to take oral medication for her agitation. In terms of past history, she's just successfully managed to deal with her benzodiazepine dependence. So she's been to rehab and everything. Yeah. So what medicine are you going to give her to help with the agitation? You're in an inpatient mental health unit and the patient's agreed to take medication orally, so you don't need to worry about giving it to them intramuscularly, restraining, all that unfortunate stuff. Haloperidol is a good option and was up until recently the most common for this thing, but now opinions have slightly changed. So you'd think of a benzo, you could think of a benzo if it wasn't for the fact that she just stopped being addicted to benzodiazepines and you don't want to risk her relapsing. But I see where you're coming, because both of you have mentioned, actually between the two of you, you have covered 3 out of 5 of the options on that SBA. So haloperidol was one, chloride epoxide was a benzo, and lorazepam, which are both benzos, rather. Olanzapine, perfect. So olanzapine has now become the third option for dealing with acutely agitated patients on a mental health unit. Haloperidol seems to be more of a, nowadays at least, delirious patient on a physical health, sort of a medical or surgical ward. But now olanzapine is preferred, mainly because as a one-off dose, it's not going to screw off your metabolic, your metabolism, and you're less likely to get something like a dystonia afterwards. Perfect. Congratulations, you got a finals SBA right, Francesca. You're ready to go. So things to think about with if they weren't contraindicated, your options go between lorazepam or basically a benzo or an antipsychotic. So there's no actual strict first line, but people tend to prefer olanzapine because it's not going to give them a dystonia like a typical antipsychotic, and there's no risk of dependence. Whereas the problem is, benzos, it feels quite nice to take a benzo. And if you give a patient a benzo, what might often happen is they'll say, can I have that again? Can I have that again? And what you might see, you might have seen on your site placements, is that patients start demanding it and demanding their lorazepam. So it really depends. And during my psych placement, when I was at Highgate, they preferred giving an antipsychotic. And when I was at St. Pancras, they preferred giving lorazepam. So it really, really depends. Sorry, it's not a very satisfying answer, Eliana. But the most preferable one is olanzapine. If there was no contraindications, you still have like those 3 options of, do I give them a typical, do I give them an atypical, do I give them a benzo? I'd probably go for an atypical, just because there's no risk of dependence, unlike with benzos. The patient's not going to come back asking for more of it, which isn't good for them. And there's little risk of me coming back half an hour later and the patient's got an acute dystonic reaction, which really, really hurts. I hope that makes sense. It's not a very satisfying answer. Okay, so we'll actually quickly just talk through the antipsychotic stuff. So remember, receptors equal effect, help with side effects as well. So quick run through. Unlike SSRIs, they're quite safe in pregnancy, and also you don't want a patient to become acutely unwell during pregnancy, so usually they're kept on. Breastfeeding isn't great, but again, you'll usually still see them on it because you don't want them to become very unwell in the postnatal period. Efficacy is the same, apart from clozapine. We've talked about agitation. I'm really sorry if that's the words are really, really small. Sorry about that. Important things you can give it as an IM injection. What sort of patients get IM injections? Depot injections of an antipsychotic in the long-term set. Let's say in the community. Who gets IM injections in the community? Because you can do it acutely for a very unwell patient who's refusing to take medication and is very agitated. What about in the community? Yep, perfect. Full medication compliance. And let's say there is a patient who keeps on getting readmitted because because they keep on forgetting or don't want to take their medication. What might you put them on? As in they've had repeated admissions for the same thing, which is they relapse because they stop taking their antipsychotic, or they forget to because they've got poor insight or poor cognition. What might this patient get put on? I mean, in a legal sense, not a medication sense, not a particular medication. Yes, perfect. CTO, so community treatment order. So just for the sake of if anybody hasn't heard of that, a community treatment order is basically if a patient has been under a Section 3, which remember is a treatment order, you can impose a condition on their treatment, which is we will discharge you into the community under a CTO. What this means is that you will have to turn up, get your medication, so usually as a depot, so you're not turning up every day. If you miss that, then if you don't turn up for your medication, then and you're not answering the phone, or you're not there when the mental health team knock on your door, then you're going to be readmitted under a Section 3. So that's a community treatment order. It's sort of like, it's like being on probation from a Section 3. That's the best way I can describe it. You have almost probation criteria, and if you don't take your medicine, then you go back in under a Section 3. Okay. Contraindications are variable. There's sort of the almost absolute ones, which is like if you've got any sort of Lewy body pathology. It's really sort of very much a consultant neurologist, consultant psychiatrist sitting on the phone trying to figure out what the doses are for a patient who has schizophrenia, who has now very unfortunately developed Parkinson's disease. But it's basically almost entirely contraindicated unless there's no other way around it. And then there are things like QTC and haloperidol. If we're thinking QT prolongation for psychiatric drugs, remember the C's for the SSRIs, so citalopram and escitalopram, haloperidol, and then all the atypical antipsychotics are kind of like QTC prolongation. So those are the ones to keep in mind. And then side effects are based entirely on the receptors. By now we've said, if you block histamine 1, you fall asleep. If you block alpha 1, you gain weight, you become hungrier, and you also fall down easier. If you block antimuscarinic receptors, you get antimuscarinic side effects. And if you block the dopamine receptor, you get Parkinsonian symptoms and also sexual dysfunction because of the hyperprolactinemia. And then the metabolic syndrome is more common in the atypicals, but you can get it in the typicals as well, and it really, really sucks. Aripiprazole, one of the newer antipsychotics, I say new, it's about 20-something years old, is thought to have milder side effects than the others, however. Quickly talking about clozapine. So what's the definition of treatment-resistant schizophrenia? So we say clozapine is reserved for patients with treatment-resistant schizophrenia. What is that? Perfect. No response to two different antipsychotics. Very good. And those antipsychotics usually have to be tried for at least 6 weeks. Sometimes the rules get bent, especially with a really unwell patient, but ideally it's supposed to be 2 antipsychotics. Each one has been tried for at least 6 weeks and they're not getting better. Now let's try clozapine. So talk about clozapine monitoring in a second. Clozapine is generally a bit of a nightmare. You've got the same side effects like metabolic syndrome and so on as the other atypicals, but there are 4 other things to bear in mind with clozapine in terms of side effects and dangerous stuff. So I'll get rid of the most obvious one, which is the granulocytosis, because actually we manage that quite well. We pick up on it quite quickly. What are the other 3? So you have started your patient on clozapine, and within 48 hours, they're now complaining of a pretty bad chest pain. What's the most likely thing that's happened? Let's see. Myocarditis, perfect. So myocarditis is the most common cause of death within the first few days of starting clozapine. Good. So that one, chest pain, new clozapine, do their TROPS, call MedReg is basically what you are going to do if you are the F1 or F2 on a psych ward and they've started someone on clozapine and they're now complaining of chest pain. That's what you're going to do. Francesco, you've got one of the other 3 that I was thinking of. So sedation and hypersalivation are 2 of the big side effects of clozapine. It's worse for hypersalivation than the other antipsychotics, which can cause it as well, like really bad, like patients struggling to speak because of how badly they're salivating. And you usually have to give them some form of anti-secretory, like glycopyrronium. Constipation is another big one, which is actually the most common cause of death in the long term because they get really bad bowel obstruction. So they can get really bad constipation with clozapine. The third one is seizures, because clozapine can shut down your seizure threat. Hey, perfect timing. Yeah. So the four big, these can kill people things with clozapine: bowel obstruction, seizures, myocarditis, and the agranulocytosis. Hypersalivation is an incredibly distressing side effect, but it won't generally kill a person. But yeah, perfect. One of the other bothersome things about clozapine is that basically how long can a patient miss a dose for before they have to start from scratch with clozapine? How many doses can you get away with missing? Yeah, basically 2 days. So two doses. If they're taking once a day, 2 doses. If they're taking twice a day, 4 doses. 48 hours. If you've missed your clozapine for 48 hours, you are starting again from scratch. And clozapine titration is a hassle. Like it's really, really annoying. Finally, the monitoring thing for clozapine. I wouldn't memorize this unless it's like the night before your OSCE or the night before your SBA, because you will forget it, and in real life you can just use the BNF because it's on there. Basically, they have their full blood count done every week for 18 weeks. Then for the rest of the year, it's every 2 weeks. And then once it's reached 1 year since they started, it's every month, basically, which is a real pain for patients. But yeah, so that's clozapine. Any questions about that, then say so. And then in terms of all the antipsychotics, the sort of adverse reactions from the extrapyramidal side of things, what's the most common acute one? You've started someone with an antipsychotic, let's say haloperidol, and 30 minutes later the nurse is calling you. What's happened to the patient? So akathisia is common, but it's not the one that comes on within minutes to hours. But akathisia is very common, and that's really horrible. Perfect, acute dystonia. You come back and the patient's like this, and it really hurts, or their eyes have got an oculogyric crisis. And what do we give them? What are we going to give this patient to treat that? Because this could easily come into an SBA, to be honest. Patient has been. Yes, perfect. Procyclidine. Procyclidine is antimuscarinic, and you give that to treat acute dystonia, and that has come up in an SBA before, so just worth remembering. Fab. Okay. Akathisia, which is what Francisco said, is this horrible feeling of restlessness. It's different from restless leg syndrome because it doesn't wake you up. It's only there whilst you're awake. Restless leg syndrome can wake you up from your sleep. And it's really hard to treat, and it's really distressing. So basically, either you bring down the dose or you change the antipsychotic. And then what's the one that we never really see today? And we only see it in like patients who've been on antipsychotic, who's got diagnosed in the 80s or 70s. We rarely see it nowadays because we don't use doses that are as high in terms of antipsychotics. Perfect. Tardive dyskinesia, so the involuntary lip smacking, tongue protruding sort of symptoms that you might see in quite old patients. There have been a couple of times, I think, at the WIT where they had a couple of older patients, and the F2 was like, hey, come see this patient, or they had tardive dyskinesia. We shouldn't see that anymore, but it can be irreversible. Finally, neuroleptic malignant syndrome, which we sort of talked a bit about. We said there was more delayed onset. We said that rigidity and subsequent raised creatinine kinase because of the rhabdomyolysis is more common in neuroleptic malignant syndrome. What can we give to treat neuroleptic malignant syndrome? What's the medicine that we might be able to give? Oh, why is the answer not popping up? I can hear that someone said something. Ah, there we go. Dantrolene, perfect. Dantrolene and perfect. Bromocriptine you can do as well. So that's the thing. They always talk about dantrolene in SBAs when stuff like bromocriptine and also diazepam are quite accessible. So we've talked about those adverse reactions, and neuroleptic malignant syndrome, you can use dantrolene, which inhibits the release of calcium from the sarcoplasmic reticulum, so they don't contract their muscles as strongly. Bromocriptine, So it is the first line for malignant hypothermia, but you can also use it. You can also use it in neuroleptic malignant syndrome, because a big problem with both of them is that they are going to rhabdomyolysis because of uncontrolled muscle contraction. But yeah, really good point. So it's first line for malignant hypothermia, but you can also use it in neuroleptic malignant syndrome. Other things you'll see in them: fever, confusion, sweating, some autonomic stuff, but also they'll become hyperkalemic because all the myoglobulins giving them acute tubular necrosis. If you've never had an antipsychotic before, you are the most vulnerable. If you've got Parkinson's or Lewy body pathology, you're also vulnerable. If you're using a typical antipsychotic, you're more vulnerable because it binds to dopamine receptors more strongly. And if you have had a very quick increase in dose, you are more vulnerable. And it's got a mortality of 15%. Right, we'll really quickly go through the mood stabilizers, which fortunately are the least heavy ones, just in these last few slides. So talking about mood stabilizers, just a fun fact, they don't really seem to work by modulating neurotransmitter activity. It's actually more epigenetic, so they seem to affect gene expression by binding to histone deacetylases and other enzymes involved in epigenetics. Also, they've got things like your sodium channel blockers and so on. Divide it threefold, or twofold even. Here's lithium, here are the non-lithium ones. The non-lithium ones are basically 3 anti-epileptics are licensed, which is carbamazepine, valproate, and lamotrigine, and you've got the antipsychotics, mainly the atypicals. The atypicals are really good for mood stabilization. Acutely, you give them something like olanzapine, that's the best one. Chronic or sort of maintenance, gold standard is lithium. This is for men and women. If they can't have lithium, give a man valproate, give a woman lamotrigine. If they don't respond to lithium, it's not that they're intolerant, they're just not responding, you can use carbamazepine. Side effect stuff, I don't actually really memorize them, to be honest. But all I remember is lamotrigine. The big one for that is tell us if you get any rashes, because Stevens-Johnson syndrome. There are some mnemonics that I found for carbamazepine and valproate, which are basically their names, if somebody would like to use those. But lamotrigine and Stevens-Johnson is the big one. And then lithium. Lithium's the interesting one because it's a bit of a mess. But the most common so the real life important stuff is Addison's disease patients can't get it. Brugada syndrome, because lithium does have some sodium channel blockade activity. Brugada syndrome can't get it at all. Hypothyroidism because it's thyrotoxic. And because if you go into an AKI, you will go into lithium toxicity, almost certainly. If you're dehydrated, you shouldn't get it. Also, if anyone's losing fluid, so they're having diarrhea, they're vomiting, they've got an infection which is making them sweat a lot, you've got to be really careful because they might go into toxicity. So there's a lot of cautions around it. The pregnancy-related stuff, Ebstein's anomaly, really quickly, what is Ebstein's anomaly? Fun SBA. I think it's come up before for 5th year. There are a couple of buzzwords for it. Yes, perfect. Yeah, wonderful. That is the buzzword. Their right ventricle, their right Okay, we'll get to that in a second. The trough peak levels. So right ventricle atrialization. So the right ventricle looks like the atria. It's completely underdeveloped. Don't use it when they're breastfeeding. Also, the dose needs to go up a lot in pregnancy, in 2nd and 3rd trimester. The stuff that everybody remembers, nephrogenic diabetes insipidus, it makes your psoriasis worse, it messes with your thyroid and the fine tremor, but also remember it's teratogenic, like a lot of the other, basically all the other mood stabilizers. It can make acne worse as well, it screws with your libido, and it's got lots of GI side effects. Monitoring, so trough doses, lithium is trough, you take it 12 hours after a dose, says taken between doses, and the monitoring is fortunately less annoying as schizophrenia. It's as clozapine, it's every week until the levels are stable. Optimum is between 0.4 and 1 millimoles per liter of lithium. However, if they're acutely manic, you usually try and go for at least 0.8 to 1, because they need more. And then it's every 3 months once the levels are stable, and then you do that for a year. Then after a year of initiation, it's every 6 months. You also do your regular blood tests and monitor them every 6 months. Overdose is often triggered either by toxicity is either triggered by they've deliberately overdosed or they've gone into an AKI because of NSAIDs or diuretics or something along those lines. And fine tremor turns coarse. It's like you'd stop it immediately because lithium toxicity is going to kill them before they got manic. Like if they go acutely manic, then you just do a section 5-2 basically, and they can't leave. And whilst they're in hospital, they're not going to do the things that make you die from mania, like risky behavior. So yeah, you stop it because of the toxicity. So the fine tremor turns coarse, visual defects, and a lot of autonomic stuff. So it's the arrhythmias are what kill them. The important thing is because it's kidney stuff, it's dialysis basically. If it's kind of mild, you don't give them diuretics because they might go into an AKI. You just give them lots of fluid so that they flush it out in their urine. If it's severe, you've got to dialyze them. And in some places, if it's really bad, they will like do full bowel irrigation or gastric lavage. This is one of the times where you don't use activated charcoal, not because it's a bad thing, just because it doesn't work. It doesn't actually bind to it, because lithium is a cation, being a metal, and because it's charged, activated charcoal can't bind to it. Fun fact. Right, so that's lithium. So because we rushed those last two, just quick important points from them. Acutely, antipsychotics are best for mood stabilizers. Lithium is gold standard. Watch out for rashes with lamotrigine. That's basically the SBA stuff. There'll be lady had bipolar. Now she's come in and she's feeling really unwell and she's got blisters. What is this? That's an SBA that comes up. Lithium, again, cram the monitoring stuff the day before the OSCE or even the morning of the OSCE. That's what I do. And Epstein's anomaly is the SBA obs-and-gynae one. Fine tremor turning to coarse is the overdose one or toxicity one. And what triggers the toxicity, AKI, or anything that messes with your kidney, how do you treat it, hemodialysis. That's your SBA high yieldy stuff. And just a last slide for you to look at later is just general monitoring. Really, it's just antipsychotics that have the most rigorous monitoring. And honestly, that doesn't often get done, which is really not great because you should be monitoring with these medicines. You see the antidepressants don't often need a lot. It's just long QT with citalopram and escitalopram. So lithium whilst you're taking lithium, you can get a quite fine tremor. But once the person goes into lithium toxicity, that fine tremor becomes quite coarse. And that's something that can be a giveaway that someone's gone into toxicity. It's like, do your hands normally shake? Nowhere near as much as this. Okay, you've gone into toxicity. That's not great. And yeah, valproate, LFTs, carbamazepine, you just need to check the blood levels to make sure it's optimum. It's just antipsychotics, which you are monitoring basically everything for a good period. Right, that overrun, sorry about that. And we didn't get to do mood stabilizers very much, but basically that's everything you need to know about psychopharm, really. That's all the stuff that either SBA stuff, and then the OSCE stuff is really just explaining the medications to people. And if you take that SSRI template and just sort of adjust it to whatever medication you're talking about, because it's either going to be an SSRI or an antipsychotic, just adjust those and you're golden for that station. It'll be perfectly fine. But yeah, I hope that was useful. Again, sorry for overrunning. Would be very, very grateful if you could fill in the feedback form, which has just gone into the chat. I'm going to stick around until everyone's gone for any questions. And yeah, again, put in the sort of stuff that you would like covered in later fifth year stuff. It doesn't have to be just psych stuff, but any psych stuff, put that in. If there's other stuff for fifth year, then Anush and I will have a look and we'll cover those as well. No worries, guys. I'm glad that was off use. Let's stop the recording.